Hello, everyone. We will get started in one moment. Hi, it's Deshaun again. Just a quick kind of meeting reminders. To encourage engagement, please make sure that you turn on your videos, mute your microphone on entry until you're ready to speak. Also, at this time, if you could put your name, title, and organization, if any, in the chat. And if you would like to make a comment or question during the time, please raise your hand. If you're not a member of the task force, kindly hold your questions till the end or put those questions into chat. Thank you.
Get to the other one. afternoon, everyone. It looks like we have a good number of participants online, so I think we'll go ahead and get started. It is 4:06 on Tuesday, February 28th. I will call the meeting to order. Thank you so much. It's great to see everyone here for our second meeting. Today's agenda, this go round, it was a collaborative effort from your three co-chairs plus our support through Deshaun Groves. So we have a welcome and overview. We will move into the observations of individuals with lived experiences, which is a segment we'd like to have at every one of our meetings just to really root us in the reasons why we're here and the work that we're doing. And then we'll turn over to one of our co-chairs, Amy Danielson, to walk us through a perinatal mental health primer. So we all have some basic information or shared basic understanding of what we're talking about. And then we'll go into the overview and discussions of our proposed subcommittees and how that work might be structured going forward. And then we'll close with public comments and then come back in a month or so for our next meeting. So with that, Nandi, if you're here, I'll turn over to you to tell us about your experience as a new mom and your perinatal mental health overall.
Hi, thank you. And of course, thank you everyone for being here. A little bit about myself, I'm a mom of two. And when I had my second daughter, it's when I experienced the most trauma. A lot of people don't know that she came from assault. So within that experience, it was a journey that I had by myself. And because I'm in a family dynamic that really values, come from a religious background, I was really not discarded, but pushed away for our support with my family because the assault happened and it wasn't. But through that, I experienced trauma from the hospitals and people not supporting me during the breastfeeding part, and then afterwards, even doing like my postpartum experience, that's when I met Patricia Quinn and started feeling like a sense of purpose and speaking for moms that experience racial bias, trauma, anxiety, and depression, because when you're a new mom, there's no handbook. Like there's nothing there, especially a single mother. Like there's no one there to support you. And then you're having backlash from family for needing like assistance from the state. And then you want more for yourself, but the state is so expensive where it's no middle ground for you. Even like now, as I work, I've been doing this work as someone with lived experience for 3 years. And it's frustrating to still be in a position of like poverty, because it's like you're kept in that level of like, we need you to be the lived experience person. Not saying this is the people in this team, but it's like, we need you to be the lived experience person. Like, your passion is worth that, but we're not going to extend you further. And it kind of is depressing, especially with somebody that's already dealing with anxiety, depression, PTSD. It's like, me as a mother, how can I expand myself when my community is shunning me for being a single mother and the system is not supporting me as a single mother? It's like, how am I supposed to advance? How am I supposed to heal when I have two little people that's dependent on me? It makes me more depressed. I remember in September of 2021, I attempted suicide. I attempted suicide because I couldn't find a job that supported me as a mom. Like, I would get so much backlash for having to call out my kids were sick, for needing to go to their school. When my oldest was in therapy, the therapist told me, well, she needs more attention and more care, and she needs maybe like help create a village. I'm like, well, how? How am I gonna create a village in the middle of a pandemic? So I felt like my kids didn't deserve me. Like I felt like they deserved a mother that was capable of having juggling multiple jobs and take care of them at the same time. And so I attempted to leave. Um, I couldn't get, because I was working, I was making $15 an hour. I couldn't get food stamps. I couldn't get TANF, child support. He's on child support, but they don't enforce it. So I don't get child support and I have to work. But then my rent go behind and you can't, then your car note goes behind and then your credit score goes behind. It's depressing. And, thankfully the attempt didn't work. It didn't go through. I thank God for that. But it was a process afterward because I became obese. I became pre-diabetic. And I still didn't have no support. I don't have no support. I thankfully now I have a job at Mary Center that helps. I thought, and when I became working at Mary Center, that it was going to help me more because I was having a job, but now I'm over the poverty line. So I'm back at, okay, you're back poor, where my rent is 1 month behind right now, and my car note is 2 months behind and I can't get food stamps because when you work, they think you don't need food stamps. And as a home visitor, I love supporting my families, but I can't support myself. I just testified the other day, every day I have to like mentally separate my motherhood to be present for my participants. But it's like I constantly try to have to get other jobs to, supplement everything I have to have. So now I have to work 2 jobs. Now I have to be here with the Maternal Health Equity Lab in DC Next, and now here, and I'm just like, okay, I'm on this task force, but I wouldn't have been where I'm at now if I wasn't like advocating in these sessions. So that keeps me going because it's like there's a glory road down the road. Like maybe within these sessions, I will get a sustainable job. So that keeps me sane. It keeps me going, and I'm advocating for so many mothers. And I know from the first time I spoke, Miss Melissa Bird spoke about this before, that my testimony from when we spoke the first time about doulas needing to be within the homes to help mothers, that's important because we know we have a lot of single mothers. They need help inside. When I had the money during the pandemic to pay for a maid because I was depressed and they gave me the child tax credit, I felt so great. So I know I can go on and on. I don't even know how much time that I'm on. Just to say, I'm grateful for this task force to help mothers like me who is filled with has a whole bunch of stressors. And also this task force helped create a purpose that we are just hope that it brings more income for my family as I grow within this field. So yeah, it was a lot, but I hope I was around in a lot of circles. This is someone like meet me.
Thank you for sharing. And I'm just, what courage to share all of that with us. So thank you for trusting us with your story. And I'm sorry you were in so much pain that you only felt like there was one option out. And I am too glad that that's not how it worked out for you. We're much better group today because you're with us, Nandi. So thank you so much. I will. So when we met as the chairs, myself, Nandi, and Amy, And really, we are having I think what's kind of the typical conversation, at least from my world and policy perspective, about these different things. And every time, Nandi was speaking up about obviously her experience, and I'm thinking about my experience and those differences, it's kind of like we can do a lot of the system changes, but it's also how do we get folks to understand kind of what that is for the individual experiencing things. Because we can put all these great things in place, but if you don't know that if, you're having a bad day, and in some neighborhoods or in some families or communities, maybe that means there's a call to child and protective services, then you're not going to understand, that's what some of the folks that you're working with are experiencing. And so we wanted to make sure that we're starting to share kind of the lived story, so we have that at our base, and really understanding of how we're thinking about everything from the discussion point, and not just about the different kind of supports that we can bring as a system, but how do we help everyone that's involved in it to be thinking really holistically and from the various perspectives of the folks that might be moving through that system. Most importantly, the moms who are there. So we look forward to having this time devoted every task force meeting to keep that front and center for all of us. As always, when we start up a task force, it's really helpful to make sure we have a similar baseline of understanding or of information. Amy was kind enough to volunteer to present an overview on perinatal mental health, defining what does it mean, and what are some other different components to when we talk about perinatal mental health. So I'm going to turn over to Amy for the next several minutes to walk us through a great presentation. And then Amy, if you could just direct the task force members if you'd like it to be more of a discussion and take questions throughout, or if you prefer that to have those reserved to the end, and we'll respond accordingly.
That sounds great. Thank you so much, Nandi, for sharing and starting us off. I really feel like that was the best place for us to start today. And a lot of things I'm going to be talking about are things that I know Nandi has heard before. I know that many people on this meeting have heard before. It will be a review for many folks, but we all thought that having a kind of a common basic level of understanding about some of the issues that we're going to be talking about would make a good sense as a starting point. I'm happy to have there be questions as we go. I have slides to kind of move things forward to try to present a high level, little bit of information on a lot of things. And so if someone asks a question in the chat, Melissa, if you don't mind flagging it for me, that'd be great if I don't see it. And I'm going to share my screen so that we have some slides so that we can all sort of see some of the statistics and some of the data that I will be talking about. Bear with me one second here. And are you all seeing that screen? It says perinatal mental health on the top. Okay, amazing. All right, and so we are going to start in with like an overview of talking about some of the conditions that we're talking about themselves and how prevalent these are, just to root us in the data. So anxiety and depression affect, we think, about 1 in 5 individuals during pregnancy and the first year following birth. And so this is the perinatal time frame that we're talking about. It's about a 2-year time frame, all through pregnancy and the first year following birth. We're going to talk more about this later, but when we think about higher risk populations, in particular, Black mothers, women living in poverty, immigrant mothers, and others, we'll talk about others, we think the risk is about 1 in 3 women, individuals will develop a mental health condition during the perinatal period. Many people don't realize that these are, hang on here, there we go. These are the #1 complication of childbirth and pregnancy, more common than gestational diabetes and preterm delivery, prematurity, preeclampsia. This is the leading complication, mental health conditions. And what we also know with more recent data is that suicide, postpartum suicide and overdose combined are the leading cause of death in the first year following pregnancy. So again, this 2-year perinatal time frame that we're talking about, the conditions that we're talking about are major depressive disorder or depression, bipolar illness, anxiety disorders like generalized anxiety disorder or panic disorder, obsessive compulsive disorder, post-traumatic stress disorder, substance use disorder, and psychosis, in particular postpartum psychosis. So any psychiatric disorder can occur during this period. These are the ones that we see tend to present or recur with most frequency. They're called lots of different things. They're called maternal mental health conditions or perinatal mental health disorders, perinatal mood and anxiety disorders or illnesses. The people who experience these conditions are mothers, women, childbearing people, pregnant and postpartum people. So this is the vocabulary, and I'm going to use kind of all of these words interchangeably over the next 30 minutes or so. I wanted to sort of root us in a really important statistic, which is that I think all of us know that the United States has the highest rates of maternal mortality in the developed world. And each year, about 700 women die during pregnancy or the first year postpartum. We have this information based on maternal mortality review committees. This is how we learned that suicide and overdose are the leading cause of death in the first year after a woman or an individual has a baby. And this accounts for about 20% of all maternal deaths. The peak incidence of suicide is about 6 to 9 months postpartum. So we're talking about the second half of the first postpartum year when most birthing individuals have concluded their care in the obstetric setting. And if they're seeing a doctor regularly, that doctor is most likely to be their child's pediatrician at this point. And I wanted to also mention that the way we think about suicide is 100% of suicidal deaths are preventable. So 20% of all maternal deaths are preventable if the right treatment and access to treatment is in place. So some facts and figures, these are the #1 complication of pregnancy. About 1 in 5 pregnant postpartum people are going to develop one of these conditions. This rate tripled during the COVID pandemic. And what we think is about 75% of individuals that experience a perinatal mental health condition go untreated. And that statistic I think is in part why we're here today, is to close this gap. What we also know, a lot of times people think about postpartum depression, and I think that's the thing that's talked about most often when you're talking about these conditions. But what we know is individuals like myself that treat postpartum depression and anxiety, is that maternal mental health conditions often start much earlier than the perinatal period. When you grab a group of women that have depression in the postpartum, the statistics show us that about a third of those women, maybe 40% of those women, develop their symptoms after their babies are born. About, a third of them or so, roughly, develop their symptoms during pregnancy. And they get on their radar or someone else's radar when they get worse after their babies are born. So they develop symptoms in pregnancy. Close to a third of individuals will actually go into their pregnancy already depressed. So these are individuals that have pre-existing psychiatric issues or mental health conditions, pre-existing conditions that are worsened by the circumstances surrounding pregnancy and their delivery. And so thus, one of the things that's actually one of the favorite parts of the work that I get to do is that there are a lot of individuals who have been really struggling to get connected with mental health care that are screened in pregnancy and can be screened in pregnancy, connected with a provider. And for many of those folks, if they get the treatment they need, they will feel better than they've ever felt before, even prior to their perinatal period. What we also know is that if women don't get treatment, that the studies show us that about 3 years postpartum, about 25% of individuals still have elevated depression about 3 years postpartum. And what's happening at this time? For many individuals, this is when they're getting ready to have their next baby. So they're going into their next pregnancy. 1 in 4 of them, they're going into their next pregnancy then already depressed. These illnesses are we think of them as biopsychosocial illnesses, affected and influenced by biological risk factors like a person's mental health history. Having had depression before predisposes your risk for depression. Your reproductive history. There's a woman I'm working with now who has a history of 9 prior perinatal losses, and she just had her very first living child and has been struggling with lots and lots of anxiety connected to her reproductive history. General health is a factor as well. Personality and behavior is a factor. Relationship, whether you have an existing relationship, whether you have a partner, whether you have the support of a partner, whether you have the support of a family, mothers, sisters, your expectations for the experience are part of the psychological risk factors. And then social factors, a prior experience of trauma, social changes, social stressors, a loss of a job, a change of a job, racial injustice, poverty, economic inequity are enormous and potent and powerful risk factors for all of these conditions. COVID itself also, as I mentioned, caused much more depression, anxiety in the perinatal period. Anxiety surrounding what happens if you get COVID when you're pregnancy, if your baby would be affected, whether you should get vaccinated or not, that a lot of women who were pregnant and postpartum during the pandemic were profoundly isolated and alone. It created issues with childcare, with kids being home from school. There was enormous stress and anxiety. And from the other clinical leaders that I know that are running clinical programs, that the volume of referrals to the clinical programs over the last 3 years match this. There has been about a 3 to 4 increase in volumes of referrals and needs for services as well. So women that are at an increase, all women or all birthing individuals are at risk. Birthing individuals that are at the highest risk are women that have a history of anxiety and depression, single birthing individuals, those without a partner, those who have experienced trauma, those that have faced economic and racial inequities. We'll talk more about this. Immigrant women that are away from their family of origin. They may have children that were left behind. There are language barriers. There are cultural issues. There is a lot of rhetoric around deportation that is chronically stressful and a problem with access to care. We also know that military mothers, military birthing individuals are also away from their family. There's frequent moves, deployments, and war. All of it compounds the stress and strain during the perinatal period. And we also think of our parents with a baby in the NICU as a special population, that concerns about the health of the baby, that a traumatic delivery experience, birth trauma, fears about the mother's life and the life of the baby predisposes risk for PTSD in the postpartum period, as well as depression and anxiety. The NICU itself is a stressful environment. Many experience the environment itself as traumatic. The separation that's involved from their newborn, their other children, all of those stressors increase the risk that is already present. That we think about basically 40% of Black mothers experience maternal mental health conditions. They're at the highest risk. They're least likely to be screened, and they're the least likely to receive treatment, despite being twice as likely as white women to experience these conditions. And we think about half, and this is nationally, about half of cases of postpartum depression in particular in women of color go unreported. And the factors are the factors that I think Nandi spoke about. to start us off today. And I think she brought those to life for us today. And hopefully, you know, we will continue to have these in mind and center these in our purpose as we plan for change. When people ask the question about sort of why these conditions are more frequent during this period, the answer is really that we don't know. We think that there's this sort of perfect storm of hormonal changes that happen during this period, sleep deprivation, enormous identity transition, oftentimes unrealistic expectations for a pregnancy and for the postpartum period, particularly if the transition affects or includes things like disappointments or trauma surrounding childbirth and the initial postpartum period. Being predisposed for depression and anxiety, having lack of access to healthcare. These are sort of all the factors that come together and give way for why these conditions are just so enormously prevalent. And so I think when we think about, I think all of us care, that's why we're here. But I think when we talk about why we should care, there's some important science that I wanted to put in front of you. And that is that we know that in addition to the fact that we want our birthing individuals and mothers in DC to be healthy and happy and well supported, we also know that when they're not, when they're depressed or when they're anxious in pregnancy, that poses considerable risk for themselves and their babies. We know that pregnant people that experience these conditions are more likely to have poor health in pregnancy, engage in poor or absent prenatal care. They're more likely to use substances, alcohol, tobacco, cannabis, and that it is because of this that we see higher rates of or an increased risk for negative birth outcomes, higher rates, risk for preterm labor, low birth weight, prolonged labors, higher numbers of NICU admissions. So negative birth outcomes that we know are connected to untreated, undiagnosed mental health conditions in pregnancy. And then when we move to the postpartum period, those risks continue. It's almost like a snowball rolling down a hill. That if women are depressed in pregnancy and they're not offered treatment in the postpartum period, we see them really struggle with the parenting, the parenting task. They're less responsive to the baby's cues. They're having fewer positive interactions with their baby. Many are having breastfeeding difficulties. And I point this out not to be critical of a new mother with depression. It's really she's doing the very best she can in a very high demand situation with an illness that affects really every life domain. And so women who are with young babies who have untreated, unaddressed depression and anxiety are more likely to experience impairments in attachment with their babies. There's a higher risk for behavioral, cognitive, developmental issues in their developing child. That these risks are sort of cascading, and I would say cascading and growing over time the longer you have a parent with untreated, unaddressed depression. There's an impact on fathers as well, and I think that maternal depression is the #1 predictor of paternal depression, and we think about 1 in 10 fathers experience a perinatal mood and anxiety disorder as well. They often express their conditions a little bit different. That anger, frustration, stern discipline can often be a manifestation of depression in an expectant or new dad. And we know that depressed parents overall are more likely to overuse the healthcare system, the ER, the ED. They're less likely to adhere to guidelines, safety guidelines for their kids, safe sleep, safe car seat usage. And again, these parents are doing the best they can, but they are that they are impacted and limited by the severity and breadth of mental illness. There's societal costs as well. Many of the individuals that we work with that experience depression, anxiety, PTSD, psychosis in the postpartum period, that they're one and done. We think of them. They have one child and that's it. They don't have another. That a lot of times there's an often impact on their relationship with their partner, with their other children, and there are enormous societal costs as well. And I can share more data on this. This is just a very high level snapshot of an economic study looking at the costs of untreated depression for a mother-child dyad. And the costs are, as you can see, are enormous. But the good news is that these conditions are temporary, often temporary, and they're treatable. And mothers and babies and families, birthing individuals can and do recover every day. I'm going to talk a little bit about treatment and then we'll pause after that and tee up a couple of topics maybe for our next meeting. So very briefly and generally, that there are various steps to wellness and that we think of the lowest cost and the lowest barrier starts with self-care. And a lot of times, a lot of the work that we do in therapy and a lot of the work that doulas do with new mothers and that perinatal birth workers do with new mothers is focus on the importance of a birthing individual's own sleep, her own nutrition, her ability to move her body, and her ability to have time for herself. And that these are the foundational blocks on which we would sit social support, and whether or not that's from a woman's sister or mother or friends or a support group or a doula or a home visitor, that the social support sits on these basic self-care items, elements, I should say. And then as for many women, this is enough. That's it. That's what they need to be well and to be happy and to be able to take care of their families and to live their life and have, but for others, therapy, individual therapy, counseling, and medication are tools that we layer on top to be able to help women achieve wellness. Some of these self-care elements, and we're not going to go through each of these, but I just want to, for those of you that don't spend your time kind of in the trenches of working with birthing individuals, and maybe haven't had a baby recently yourself, these things may feel further removed. And so self-care starts with sleep and exercise and time for yourself and being able to eat and have adequate nutrition. So that essentially the analogy that therapists use with mothers is sort of mothers putting their own oxygen mask on first so that they can then care for their babies. And this is where we start in treatment often. And different forms of social support can be helpful in different ways, but I think all of us that would agree that a strong social support network is going to, in many cases, prevent the development of these conditions. Emotional support, informational support, guidance, suggestions, resources, companionship, not being alone, feeling reassured, a sense of belonging, and then tangible supports, someone that can bring you a meal, make you a sandwich, that can watch your older children so you could lay down for a nap, someone that might run an errand, someone that might do laundry, so that mothers don't feel alone in this process. Talk therapy can involve lots of different approaches. The evidence base that we draw from is enormous, that shows that cognitive behavioral therapy, interpersonal psychotherapy, and mindfulness-based therapies tend to have the most evidence. They've been the most widely studied. They're very problem-focused. A lot of times, we're talking about 2 to 4 months of therapy is enough to be able to help a woman that comes in with moderate to severe depression fully recover. So this isn't years of therapy in many cases. This might be 3 to 6 months, 2 to 4 months of problem-focused intervention. And then, of course, for many of the mothers that we work with, medication is critical to limit and prevent relapse in pregnancy or the postpartum period, particularly for women who have a history of more severe psychiatric disorders. And that, that the key takeaways with medication is that for some women, it is least risky for them to stay on their medication, for many women to stay on their medication through pregnancy, with the idea, the goal of being well through pregnancy and the postpartum period. But each of these situations is very different. And women and birthing individuals have many questions and concerns, valid concerns about the impact of exposure to medication on their unborn child and the impact of exposure when they're breastfeeding their child and taking medications, which is why training for psychiatrists, for OBGYNs in reproductive psychiatry is absolutely critical, and I'm hoping we can do more talking about that. Okay, I'm going to stop because we have lots to talk about today in terms of the committees. And I think that I think I probably talked right through questions. I'm happy to answer some questions. I know there are many others on this meeting that that would be happy to answer questions as well. And we will be doing some talking about programs and resources in and outside the district, potentially in the next meeting, so that folks can kind of know models that are already out there. We'll talk more about that next time. So I'm going to end my slideshow and stop my share. And I don't know if folks had questions about any of that.
Task force members should, feel free to unmute yourself, either raise your hand, just start talking, or put something in the chat, whichever is most comfortable for you. And yes, we will disseminate the presentation. Let's call for questions.
Well, I know that was a lot of information. So if anybody has questions at any point, you can ask me in the chat, or even just after the fact, if any questions come up, or if there are any resources or references that you want some additional information about, don't hesitate to shoot me an email. I'm happy to share. I know that was a lot of information in about 20 minutes. So thank you.
Thank you, Amy. You have I see from DJ a question. We'll save that for public comment and make sure that we address that before we close out today. The next part of the agenda is to focus on the proposed subcommittees. We talked last week that generally in the structures of these groups, we have one time a month where we're coming together as a group. And that's obviously, clearly not enough time to get all the work done that we need to get done, and that we break into subcommittees where we can focus on some specific topics and really have a lot of the work happen through the subcommittee structure. So with that, we wanted to talk a little bit more about that structure and some suggested questions so that we can kick the subcommittee work off next month, which is technically tomorrow. And so for this discussion, I'm going to hand over to Deshawn Groves, who's our staff support and formerly serves as my special project officer here at the Department of Health Care Finance. And Deshawn's going to walk us through these next few slides.
Thank you, Melissa. So as the co-chairs met earlier this month, we sat down and tried to figure out how to best organize ourselves moving forward, considering the great body of work that the task force has underway. And so really and so what we have come up with is a structure of identifying kind of 5 subcommittees. And I'll go into a little bit more detail, but there are navigation and access, peer and community support, landscape analysis, screening, referral, and workforce development, and public awareness and system capacity building. And so what we're also looking for is kind of any feedback that you all have of the structure of the subcommittees, whether these are the right subcommittee topics, if there's additional work that you think is needed within them, and then also looking at volunteers to kind of help lead those discussions in the subcommittee. And so advance it. So under navigation and access, it's what barriers do mothers and families from diverse populations encounter accessing needed resources? What are their triggers that need to be addressed? What changes needed to be made to overcome identified barriers, and what strategies can be used to build trust? I will also point out that I sent an earlier document to the task force members. So they should also have that as part of the calendar invite attachments. The second one is peer and community support. How does a trust district build a network of partners to strengthen mental health in pregnancy and postpartum? Kind of thinking about what are the community-based and peer-based supports that are needed to help mothers. And then landscape analysis, what resources, including programs, treatment services, what needs assessment are needed to create a robust surveillance system, and then what kind of quality metrics are needed to improve the accountability. Then how does screening and referral and workforce development, how does the district integrate screening and referral into a broad range of programs? What are the education training do providers need on mental health? What providers need to be targeted? Which strategies should we think about to increase provider participation? And what kind of incentives or initiatives are needed to recruit and retain the behavioral health supports? Finally, the 5th one is public health awareness. How does the district raise awareness among the public and reduce stigma to encourage help-seeking behavior? What systems need to be created or connected to assist both mothers and providers? And kind of thinking about the reimbursement kind of strategies and policy development needed for these initiatives. And I'll stop there and take any kind of and open this up for task force members for their initial thoughts.
Good afternoon, Deshawn. I'm sorry. This is Felicia. So where would the communications fall under, especially when you want to communicate with the provider community as well as the enrollee community? Would that fall under the public awareness and system capacity building slot?
It could, yes. It's up to the task force members to decide where they would like to put that conversation. And thank you, Felicia, for pointing that out.
And as folks are looking through the proposed subcommittees, it's great to hear what resonates, but I think even more important is to, if you see items or questions that are missing, to please put those forward to make sure that we're starting off with as much kind of a rounded purpose for each of these groups and the questions that we want to answer. If it's perfection, we'll take that too.
I will also say that I can give task members until the end of this week to kind of ponder and give feedback, and make sure you send it to me to kind of have time to review. Amina, you just answered. I just answered.
Yeah.
So yes, task force members will have until the end of this week to give feedback. Make sure you send it to my email.
I have a comment. This is Andrea Gallico from Mary Center. Just looking at the navigation and access questions. The last question feels really uncomfortable to me of what strategies can be used to build trust. And I think that might directly relate to Deja's comment in the chat about kind of implicit bias. And I think the committee needs to think more about what building trust looks like. And I think it's being trustworthy and working on eradicating bias and providing better care. And so just want to be mindful of that. That just stuck out to me. And that same navigation and access, I wanted to clarify what it says, what stressors / triggers. And I wasn't sure I was understanding the trigger in that question, what that's referring to.
I think when we talked about it as part of the co-chairs, they talked about triggers, and so that's kind of how I captured it and reflecting some thoughts there. So it could also be that the task force ties into like what does that mean? These are by no means like set in stone, and the task force has has the ability to change the wording of these questions. These are just kind of get the members thinking about what should be accomplished under each of these subcommittees.
So Deshawn, do you think it would be fair to say that once the subcommittees are that this is really just to sort of capture the essence of what would be considered in a subcommittee, that once the subcommittee organizes, that subcommittee would generate the questions that would be answered by the subcommittee? Because presumably the people that are drawn to that subcommittee are going to be sort of the experts in how to think about setting an agenda for the subcommittee. Do you think that would be fair to say that the first task might be to define the questions that are going to be the focus of the work of the subcommittee?
Amy, I think you said it the best. So yes, I think this is just to try to get the members thinking about what each of these subcommittees what those conversations could look like. Not that these are the conversations that need to happen. So the subcommittee will definitely be deciding what needs to be accomplished under what questions they're seeking to address. Thank you for clarifying.
Awesome. And I'm also wondering then if there's like folks that think there needs to be more subcommittees, that like given that we now all have more time to kind of go through this, like if there's something that's altogether missed, there needs to be another one, that it sounds like you're open to that too.
I don't want to, this is also, I'm volunteering staff time here, so I don't want to, I'm trying to balance staff bandwidth as well. But if there is something that folks feel like they're really passionate about and it's not being addressed in one of these subcommittees and needs a separate one, please point that out. And of course, I will bring that back to the co-chairs to kind of make the decision.
So I think the biggest or the main ask from the task force members for this meeting then is by the end of the week, I think the priority is to confirm whether the 5 proposed subcommittees make sense and cover broadly the right topics and what folks really emphasized during our first meeting when we went around to each member and talked about kind of why we're here, what we're hoping comes from the group. And then if you have already some thoughts or additional questions just that you would like to see addressed by a subcommittee, include those as well, with the understanding that the subcommittee itself, once it comes together, will really kind of dig in and create or establish the purpose and the questions to be addressed through the work. Does that sound right to the co-chairs and Deshawn, since I know you'll be getting those emails?
Yeah, yes, that sounds good. And while I have time, I just want to let everyone know that it looks like the bulk of the task force members have voted to keep a monthly meeting cadence, but extend it to 2 hours. So this meeting next month and going forward will be extended from 4 to 6. I don't want to say 46 hours. That would just be too much, but not enough. So it'll be from 4 to 6 p.m. And I'll make the calendar invite adjustment necessary. The subcommittees will be, the idea behind it is that they'll be separate from the monthly meeting. So there'll be an additional time to kind of have that conversation, and we'll kind of work to make sure that they're not scheduled at the same time, so members can attend multiple meetings and that they don't have conflicts.
Thank you, Deshawn. Any last questions on subcommittees and the ask and next steps related to subcommittees? I'll take the next couple minutes to open up to any public comments. So folks who are not official task force members, please feel free to unmute yourself or raise your hand if you have a comment that you would like to be heard by the task force.
Hi, good evening, everyone. This is Deja Love. I'm the CEO of the Black Women's Wellness Agency. I'm based here in the district, a certified business enterprise, small business enterprise, former DHCF employee, background deeply rooted in public health equity. And so my lens is coming from that, my public health training, but in tandem as a DC resident community member, I really admonish the task force to be deeply rooted in what is the impetus of this task force, which is looking at the data in the district in terms of health outcomes. For those of whom I'm seeing on camera, we just observationally, it's the antithesis of the population in DC. And I really want to make that clear, that I'm not seeing many folks that look like me. We are the end receiver of the maternal mortality crises that is heavily in the district. And so I really just hope that in addition to Nandi being a lived experience person, that we co-create policies and programs that are through that lens, because there's a vast difference in disparities for folks that look like me, Black birthing persons, and it's a state of emergency. I cannot underscore that's not hyperbolic. That is truly rooted in the data. And so I just, may be a broken record, but I want it to be noted and it to be documented that that has to be the driving force. And for the clinicians, that we also really work on reframing language. Language is powerful, understanding that the disparities that we're seeing from a root cause analysis, it's rooted in medical racism, which there's a substantial body of research and literature that bolsters that. So I just want that to be really known, that we're not just ideating and constantly leading to need, but this is truly life and death for many Black birthing persons here in the district. And that everything is leading to that, because of the folks that I see on camera, your health outcome per the data is not the same for me. And that is, I don't say that for those to feel uncomfortable, but I invite you to sit in that discomfort, because that is reality, that despite my educational attainment, my socioeconomic status, even my zip code, the fact that I am Black, that transcends anything else when I access a healthcare system that's rooted in racism. So I just wanted that to be known and be documented for the record. And I welcome continuing the conversation with those who are interested. I'll leave my contact information in the chat. Thank you, Melissa, for the time.
Thank you, Deja, for your comments. Any other comments today? Thank you all for your time this afternoon. You'll see follow-up through Deshawn via email. We'll send out the presentation, and please respond by the end of the week, your thoughts on the subcommittee so we can start that work. And we'll see each other at least a month from now. I don't know the exact date. Sean, if you have it, if you can put it in the chat. And like you said, we'll adjust the meeting cadence to reflect the 2 hours. And with that, if you need anything in the interim, please don't hesitate to reach out to myself or another co-chair. And otherwise, we'll see everyone collectively as a group on March 28th. Thank you so much.
Thank you.
Thank you.